Hi everyone, I'm Scott Taylor. I'm the CEO and co-founder of Perks Health, and I'm excited to be joined by Maria Perrin and Mark Alteri from Public Partnerships or PPL. Maria Perrin, I've been fortunate to work with for a couple of years now, and she's the President and Chief Strategy Officer at PPL. Maria has a significant experience working with Medicaid and Medicare programs in various capacities. I mean, primarily as a role as Chief Strategy Officer at PPL, but also in previous roles as a Chief Growth Officer, Marketing Officer, and Chief Strategy Officer at HMS, which was a $3 billion healthcare technology company working with both Medicare Advantage and managed Medicaid plans. Mark Alteri is VP of Business Development at PPL. Mark's experience, obviously working at PPL in that capacity, but also developing client partnerships and business development at the Public Consulting Group, where he worked closely within government contracts to deliver financial management services for state clients and Medicaid recipients across multiple states and agencies. Um, Welcome, Maria and Mark. Great to have you here. We're here today to discuss the kind of lessons, opportunities, and challenges in delivering high impact programs for Medicaid populations and strategies for engaging high risk and vulnerable populations and ultimately improving health equity. Um, I'll start off by asking a few questions that I have for Maria and Mark, but we'll also then throw to attendees for a couple of questions at the end. I thought for first I might just give context of PPL and Perks Health and ultimately how we kind of are solving similar challenges despite working kind of separate areas of Medicaid. PPL is a leading provider of fiscal intermediary services for self-directed care programs. They enable consumers to choose their care providers and get care at home, along with other essential support services. PPL's mission-driven team works with 50 programs across 21 states and provides services to more than 500,000 consumers and caregivers, which is fantastic. In contrast, Perks Health, we deliver digitally scalable care management programs for managed Medicaid and Medicare Advantage plans. We ultimately engage high-risk members digitally to manage their chronic care plans, improve quality outcomes, star ratings, and total care costs. We've delivered programs for over 40,000 patients, so not quite 500,000, but we're getting there, and achieving on average 90% adherence to care plans with over 40% enrollment rates and really strong ongoing retention. I think interestingly, we ultimately work in separate areas of Medicaid, but at the end of the day, there's quite a bit of overlap, and we talk about this a lot, Maria, with the tactics, the strategies, those approaches required to ultimately enroll, engage, improve outcomes, and health equity outcomes for those patients. I mean, also at the end of the day, Medicaid patients aren't the same whether they're regardless of which program they're in. And so I'm really excited today to trade notes and share some of the lessons that we've all learned along the way. And with that, I might open up on my first question, and I'll throw it to you, Maria. What are self-directed programs, and ultimately who do they support?
Yeah, thanks for the question. It's so great to be here with you all. So, self-direction programs are a way for Medicaid members to have more control over their home care. And in these programs, many of them cover a range of services, but mostly personal care at home. The individual member can choose their own caregiver, make their own schedule, and really have some continuity of care and pick just by nature of them being able to choose their caregiver, make sure that they're getting caregivers that really meet their individual needs. These programs are typically funded by Medicaid 1115 waivers. Sometimes they're funded by state plan amendments, and there's self-direction programs, in many states, that are serving the community today. So we love to call it's almost like the best kept secret in Medicaid because it does so much good, but many people, even the ones who work in Medicaid, aren't fully aware of them.
And how did you both become aware of them? Because I appreciate you kind of both have kind of separate stories of how you ended up kind of working at PPL.
Mark, do you want to go
Yeah,
first?
yeah, sure. Mark Altieri, nice to meet you all, and thanks again for your time today. I came to PPL 17 years ago. 18 years ago, my wife and I had our first child, Jackson. Jackson went into heart failure at about 1 month and required a heart transplant at just over a year. And when your child has a heart transplant, what you find is for the first time in our lives personally, we had a loved one who needed care, skilled care, longer term care, care that we were not capable of providing for our own son, and we were reliant on a range of service providers, occupational therapists, physical therapists, speech therapists, skilled nurses, and nurses. Five. Sometimes we found that these providers were excellent and we loved the way they interacted with our son and helped him. Sometimes they weren't the best. And what my wife and I found over that first year with him post transplant was we didn't have choice and control over who the service providers were coming in and out of the most intimate setting, your home, to care for the most intimate of people, our son. And so when I landed at PPL, I learned a lot more about how this consumer directed or participant directed model can empower lots of people who have a loved one that needs long-term care and empowers them with choice and control to say, I want to control who's giving that skilled nursing to Jackson out of this network of skilled nurses. I want that control. And that's what consumer direction does for individuals. And that is why I'm still here after 17 years. And I think Marie and I will have another story or two as we go along here that will show you the span and range of people that can benefit from this model. And Maria's got a story of her own to share.
Yeah, sure. I'd love to jump in. Thanks for sharing yours, Mark. So this will be my 20th year working with Medicaid and Medicare and disability populations. And what really opened my eyes to these types of programs is when my own son was diagnosed as autistic at 20 months. And I all of a sudden went into a tailspin of what do I do? And, what services does he need? And, when I got my act together quickly for his sake, realized that a lot of what we would put in place for him was home-based. It was home-based care, home-based services. We were really fortunate because we were in California where the services through the regional centers were quite expansive. And I credit the services we got early in his development and the care with him, ending up being very successful, well-rounded young adult today, a recent college graduate. So,
Congrats.
yeah, so these programs mean a lot to a lot of people, and my career mission is to make sure that whether it's self-direction or other healthcare and support programs, that people know about them and they are able to leverage them.
Fantastic, fantastic. And you mentioned, that kind of awareness, but also, how it, being in California, that kind of meant certain things. How do these programs vary by state or from health plan to health plan?
Well, I can start, and then Mark, I'm
Yeah.
sure, has a lot to add with his 17 years of PPL. So the thing about self-direction programs is very similar to Medicaid programs in general. They're all different, right? So they vary on who qualifies for them. They vary on what you need to do to be a caregiver in these programs. They vary in the types of services. So there are some states that the services are limited to personal care in the home, such as care with bathing and dressing and, things like transportation and to get to doctor's appointment. And then there are states that really are expansive with, therapies and goods and services that may help people live a very full, rich, and healthy life. So quite different depending on what state you're in. Mark, anything to add there?
Yeah, no, that was great. And this model is primarily built on giving the individual control of their budget, their Medicaid funds,
Sure.
and giving choice and control over which services. And to Maria's point, some of them are expansive with up to 35 services from environmental modifications to assistive technologies, the core tend to be around supporting individuals with assisted daily living activities. And again, to Maria's point, the beauty of Medicaid, you get your Medicaid funding, and you as a state can choose and make a lot of decisions on the types of services to provide through this consumer directed model. And that's really the beauty and why we love going into each new state and seeing how they administer it. And that's how you learn, and that's how the model has grown and expanded over the years.
Fantastic, fantastic. I'd imagine, we talk a lot of Medicare and Medicaid plans in particular, but about, getting people to utilize their benefits and understand what is available to them. And I'd imagine you guys have a, similar kind of challenge of making people aware that the program exists or the types of services that they have access to under the various states and the various kind of rules and regulations. I mean, how do you think about engaging participants in the program and making sure that they're using those services that are available to them in an appropriate way?
Yeah, we have to engage in many different modes because people are all different, right? There are some people who will respond to technology, like, through our apps. There are some people who, like to call our call center or like our home visits. And some people, really hard to reach. So we try to get out into the community. We do a lot of community events. We do a lot of multilingual communications as well, just to reach some of the hard to reach populations. But before I turn to Mark, I'm really curious about what Perks does because
Yep.
you have a really high utilization rate on your app, and you're serving the same populations, the senior populations, the Medicaid populations. How are you all maintaining that engagement, and what are you finding are most successful for you?
Yeah, I mean, I think at the core of it, it comes down to exactly what you just said, Maria, that like different people like to engage in different ways. And I think there's the kind of mediums of engagement where we know that different populations will like a phone call, other populations will hate a phone call, much rather like, being, engaged digitally or, or via text or those type of things. And I think then the other kind of level that we've kind of really found is when you're trying to drive certain health behaviors or, certain administrative tasks, finding the thing that motivates the individual in the right way can be really important. And, often we kind of, you hear a lot of like, people, you're using incentives to drive people to like, do healthy behaviors, whether that's, your financial incentives or some other motivator. I think what we find is that there's just as many people who are motivated by, things like, gamification or community or accountability to their care team. And I think, when it comes down to it, leveraging those different strategies and different approaches and accepting that there's no silver bullet that ultimately enrolls, engages, and continues to motivate patients to do what we need them to do day in, day out. Ultimately, it's kind of meeting them where they are, and finding the solution that works for them. And I'd imagine, Mark, maybe you kind of can talk to this, but I mean, in consumer directed programs, I mean, by definition of like consumer directed being in there, like you kind of have accepted that from day one, that like different people need different solutions to get the best outcomes, and be interested to get your perspective on that as
Yeah.
well.
In this model, to successfully self-direct, you need tools, I will say. And one of them can be technology. And you know it through the technologies that Perks offers. In a consumer-directed model where we're going to give Maria control of her budget and spending, that's very empowering. It also comes with responsibility. And one of the first questions we'll hear is, what will you give me for a tool to help me manage that budget over the course of the year to make sure that I don't overspend my services?
Mm.
And that's where tech comes in. And we offer a portal where the individual can log in and see a pie chart or a bar chart showing them you spent this much in services, you have this many remaining. And that is really where technology is best in promoting care continuity, where you can give these Medicaid funds to an individual. If they have the proper tools to oversee those funds, they will responsibly manage them. And we've seen that over the years. And so it's interesting, right? How sometimes technology can be a barrier to accessing services. Then when you develop the right technologies, you find that they're actually an essential tool to manage the services.
Yeah, I think that's spot on, and we've seen that so many times where, working with Medicaid populations or working with Medicare populations, it's so easy to bring in this preconceived judgment of who will use technology or how will they use technology.
Yep.
And I think you're spot on, Mark, in that it's about building the right tools for the right people, and not trying to kind of force some one size fits all approach on, well, this worked in a, employer sponsored plan, therefore we're going to deliver it in a Medicaid managed Medicaid plan or a Medicaid population, and it's going to have the same results. I mean, that's just it's just a recipe for disaster in many ways. So I think that's super right. And then I guess you're kind of thinking about the kind of one of the big buzzwords I think of the last 12 months or 24 months is health equity, and obviously becoming more and more of a focus for CMS in many ways, and not least in terms of how they kind of think about quality measures and the health equity index. How do you feel that self-direction programs help improve health equity?
Yeah, so
So,
I'll start there. If you think about it, there is a gap in care providers for home health, right? The shortage is getting worse every day. And then when you think about special populations who maybe English is not their primary language, right? Or they need a certain accessibility, right? Or accommodations, then it gets harder and harder for them to get a caregiver that's right for them. So in self-direction, you're choosing your own caregiver, right? So, and oftentimes it could be a family member, it could be a friend, it could be a community member that speaks your language, right? Who is part of your community. So these caregivers are better equipped to serve that individual, and they're closing some equity gaps, the language gap, the how information is presented and how care is delivered gap. So that's one of the reasons it's really helping to close some of the inequities. Mark, I know you have some thoughts on this.
yeah, I mean, if you think about it, just I guess building a little bit off what Maria just said, you're talking about localizing the workforce to a degree that is desperately needed. And when you localize it, then you have the ethnic, the cultural competence, the disability competence. Uh, Equity is about access. To Maria's point, the workforce shortage is very, very real. When you get out into the rural parts of states, that's the realest challenge. And that's when you need these localized economies. It's almost, Maria and I talk sometimes, you're almost going back in time to the 50s when people actually took care of their elders and disabled more locally. Then the fabric of the United States and our economic upward mobility has driven families to separate, and you don't have that built-in communal support you used to have. It's kind of bringing us back to some of those roots, but maybe expanding that across cultural or ethnic or geographical lines, so you can have a proper support network around anyone wherever they live, as long as you have community.
Yeah, fantastic, fantastic. I really like that, and I think you call out one kind of challenge there, and we see this kind of in some of the programs we run as well, where some of these populations can be really hard to reach. They may be remote, they may kind of just be have less awareness of some of the health programs they're eligible for. How do you guys think about reaching those people?
Mark?
To Maria's point, by all means necessary. So it's multimodal communication. So when we enter a new state, for instance, it's not just a podcast, it's not just a website, it's not just a mailing, it's not just an email, it's not just a text message. It's all of the above. If that's not working, we put emphasis on reaching out to community-based organizations in those communities. And you will find nuances across community. You want to connect with this community? This is the entry point to do it. What we'll find a lot of times is those same community-based organizations are engaging with those communities to spread awareness about other services. And so we can piggyback on those opportunities. We start to build relationships with those opportunities, with those organizations, and then you start to socialize knowledge through those community-based organization partnerships. So I think a state like California, we're doing this very effectively. We have staff out in the communities, liaising with community-based organizations in all parts of the state. And we become partners, if you will, in spreading information and awareness about the program. And we learn tactics on how to engage with some of the harder to serve populations from CBOs that have already done it effectively.
Yeah,
Fantastic.
I think that's really important. And Mark hit on one of the things we do, which I don't think I've ever done in my healthcare career, is we have community liaisons. Like they're just out there. They go to community events and they talk to people and they give them whatever education they, request from us. They answer their questions. They try to get the individuals connected with the right people at either the state or their health plans to get answers and get eligible for programs. So I think that's been really helpful in reaching, the rural communities and some of the more difficult to reach populations.
Awesome. Awesome. And you mentioned like cultural and disability competency. What are some of the ways that these programs kind of improve or display these competencies?
Yeah, so they do so in a lot of ways. So I'll just go back to the first point was the choice of caregiver, right? So the choice of caregiver is going to be someone who you're comfortable with providing care, right? They speak your language. They understand, what you need from an ethnic or cultural or religious consideration. These programs also are very good at making sure that, information is accessible. So typically any information that's communicated will be available in multiple languages. There will be, teletype for people who have speech considerations. Communications are available in Braille and, are accommodate the hearing impaired and such. So there's it's a sensitivity and awareness of how to be very inclusive in the process of both communicating and delivering care. So it's really one of the best examples as a program of being cultural and disability competent.
For sure, for sure. I mean, we just did a bit of an overhaul of all of our marketing materials and all of our technology. We're kind of making sure one that it was available in Spanish because so many of the communities we work, that's kind of the second or first language. And then the other one was just making sure that it was kind of culturally appropriate and the right reading grade level, like all the marketing materials, making sure it's easy and accessible to anyone. And I think that is super, super important. So often in healthcare, we have very complex concepts and terminology, and unless we kind of find ways to communicate that in a way that someone understands, we're kind of, we're doing them a disservice at the end of the day. So I think that's super
Absolutely. I'm
exciting.
so glad you mentioned that. We last year we went through our website because our website has a lot of program information and just a lot of resource information with a fine-tooth comb, and we simplified the language. We, changed images, try to make it really easy to review and find information and understand information regardless of your situation. So I think you raise a very, very important point that all healthcare organizations should be conscious of.
Sure. And are there any other ways that healthcare programs or other healthcare programs can improve their cultural competency to meet some of those health equity challenges?
Mark, do you want to start?
Well, I mean, I, Maria Perrin, I've got to say, brought concepts like developing photonovellas for
Amazing.
non-English speaking families because that's a medium that resonates with a certain demographic. And so we're working with the state of Oregon right now about the content of what you're trying to communicate is important. The mode of communication you need to think both creatively and like Maria has brought in a cultural competency consultant to help us think through of different vehicles to get the information out. So in Oregon, we're working on Powtoons. Powtoons are like simplified, cartoonish, like 30-second clips that can help communicate simple concepts in a multitude of languages through short video clips. And you can see where, you can make those endless from a cultural and ethnic standpoint. Maria's talked about podcasts, and it's really just explore, making sure you're ever mindful. People, we hear it growing up. People learn in different ways. They consume information in different ways. The methods that you use cannot be relegated to PDFs, Word documents, wordy manuals. You have to get creative. And so a photo novella is just such a prime example of a way to communicate with certain populations, a way that's comfortable for them.
Yeah.
Yeah, and I think, oh, you go, Maria.
Yeah, no, I was just going to say, I want to expand on that, that it's really important. It's not only the proper language, but what is the mode that people are comfortable with, and will comprehend well and be interested in. Would also say, like, when you're talking about disability, or people who are differently abled, for example, I mentioned my child is autistic. Many people who are autistic have auditory processing issues. So if they're standing in front of a healthcare provider, and the healthcare provider is spewing things out at them, right? Using language that might not be crisp, or talking fast, or using uh, jargon, if you will, it might be very difficult for that person to really understand what they're asking, what the provider is asking of them, or even understand the instructions of what they need to do to maintain their care. So, having very clear, crisp, simple language, being direct, having a visual of what you're trying to communicate for people who prefer visual processing versus auditory processing. So there's lots of things we can do in the healthcare system to just understand who is this consumer, and try to meet them where they are, right? And
Yeah.
I think we just don't do that. Like, we're starting to get things where, yes, you're seeing a lot of things in English and Spanish now, but we speak hundreds of languages,
For
folks,
sure.
in the US. So, can we accommodate those other speakers? And can we accommodate people who, may have processing issues? And can we accommodate people who have religious or cultural considerations, like needing certain genders to providers who to take care of them, or not being able to take certain medicines? I think we just have to, have this in our DNA as healthcare organizations to understand people better.
Yeah, it's funny because I think, often I get asked, particularly on the technology side, and with AI being the buzzword of the last 12 months, is what are the really exciting, like, technical advances that you see in healthcare as a result of artificial intelligence or technology more generally. And in some ways, I think in some way, some of the most exciting and maybe most impactful kind of applications you can think of is that kind of everything that you've described, in that it's ultimately meeting people where they are, kind of figuring out the right way to communicate with an individual. And one of the things that technology and AI ultimately enables us to do is personalization at scale, and in very different ways. And it's I think the kind of first wave of a lot of, like, digital health was taking what was the status quo. And so, Mark, you mentioned the PDF. I mean, the PDF is, like, effectively what we used to do in, you'd walk out of your PCP office, you'd be handed a physical
Yep.
piece of paper. And the first wave of digital health was often, well, we're just taking that and we're putting it on a website, or we're putting it in an app, and not actually acknowledging, well, actually, technology enables us to do this in very different ways, very personalized ways, and to meet people where they are. And I think what I get excited about with AI is, like, actually just quite simple things of, it's very easy to say, translate something into a language, or change the reading grade level, or come up with a different medium, an infographic or a video, in a very short space of time at a very low cost. And the ability to do that at scale in a personalized way is, can arguably have just as big an impact as, using AI to find a specific new drug or therapy if we can actually just use your technology to meet people where they are, as you described.
Mhm.
I appreciate we're just on time. I might kind of take one final question from that's come through the Q&A, which was, I guess, how do you think about the future of, I guess, your care at home, self-directed care, and people, aging in place, I guess, is the kind of big theme.
It is. So let me say that the COVID-19 pandemic, uh, we think changed long-term in-home care delivery pretty permanently. So post 2020, statistically, consumer directions grown on average 20% in every state. Uh, Multiple reasons, right? A lot of people left the direct care workforce during the pandemic and did not come back. Two, during the global pandemic, we saw really the acceleration of the gig economy and the emergence of that. And this younger workforce that likes the flexibility of having multiple jobs. I can drive an Uber and I can take care of grandma, and actually on her schedule and mine, and drive my Uber on our schedule. That is culminating in a major, major workforce crisis nationally. And so you don't have home care agencies that are presenting as attractive an offer as they were in the past. And so the reliance on consumer direction, we see only going up, 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 and slowly starting like home care delivered in the community versus an institutional setting rebalanced over the last 30 years and shifted more to home and community based. Those of us in the field of consumer direction see more growth for the model as workforce. We also have a huge demographic issue in this country, as most people may or may not know. It's called the silver tsunami. And in 2030, every baby boomer will be Medicaid eligible. Uh, that's an unprecedented challenge I liken to climate change. It's happening every day. It's getting worse. Might not be in your personal face, but it's getting worse as a country. So we do see the continued expansion of the model and really a tipping point that it will become the primary model over the next 5 to 10 years.
Yeah,
Yeah, Mark,
super.
it might be helpful to you've been in self-direction for 17 years, and I know you've met a lot of people using the services. And talking about like how we have a care crisis right now, a dearth of home care workers, and how this program has been helpful for so many. Can you talk about any of the consumers we work with that really
Yeah.
had benefited and had, no other options, but maybe to go into a facility care, which I think most of us don't want, right?
Yeah, yeah. So we started, Maria and I gave each of our personal stories as parents, caring for our younger children. So one of the greatest people that I've met in my 17 years was a 65-ish year old mom named Ruth, who had a 45-ish year old grown son, Mitchell. And she was at a life stage where she was starting to think about life planning for Mitchell and getting a social support network around Mitchell for when Ruth was no longer around to be able to help care for him. They were in rural area of their state. Workforce was not readily available, as we've talked about. And Mitchell also had preferences of people that he liked to work with. One thing we haven't mentioned during our discussion is in consumer directed programs, caregivers tend to stay with that individual for years. 4.5, 5.5, 6.5 years on average, depending on the state. Home care, the attrition rate is a lot higher than that. And so here we have the life cycle of the aged parent who wants the aged adult who can't care for themselves to have long-term care when they're gone. Then another story of two sisters. And again, I'm talking about a sister in her 50s caring for her sister in her 40s who was a quadriplegic and also in a rural area. Uh, Annie, who was the sister taking care of Jane, loved technology, and that's why I liked to bring that up. She wanted to self-direct, and she wanted her sister to self-direct so that she could support her on the tech side and help onboard her to make sure her sister could manage her own services at some point without her direct involvement. And so you see another angle of, again, aging. Family impacts, family relationships come in all different flavors, as we know. And this model opens up and again takes us a little back in time where friends and family can be looked upon to provide not temporary care, long-term care engagements over five. Annie had been providing services for Jane when I met them 7 years, eight
For
years.
sure.
She's it went on for another 7 or 8 years, and that those are two of my favorites to just try to give you the full spectrum of all the individuals, the different life stages that have a loved one that want to protect their choice, control, independence, and empowerment, and help them get that set up for themselves.
Yeah, it reminds me a lot of actually one of the webinars we did a couple of weeks ago with Dr. Mike Cantor, who's has had a multitude of roles in kind of in Medicare plans, but he's a geriatrician by training, and was talking about how the fact that he and all his fellow geriatricians were retiring, and in a bitter irony, there's not as many geriatricians coming up to look after them, and that kind of that shortage of the silver tsunami, as you say, Mark, and I guess one of the exciting things about kind of the model that the PPL is doing is you're helping kind of unlock that underutilization of caregivers in a sustainable way where they're
Yes.
not being asked to deliver care, at a sacrifice to kind of their own, financial position. But I guess you touched on technology there. I'd be interested to kind of understand what technologies you've seen be working really effectively in kind of helping that person, those people maintain independence at home. And also, I guess you're probably supporting caregivers as well, in making sure that they're able to kind of, manage those people effectively.
We think, I mean, it wasn't PPO bringing this technology. It was the federal government saying a technology called electronic visit verification, which is a phone-based application, was going to be the new way to both collect time for the services being delivered, but honestly, to provide better oversight and transparency on the services, because at that point, they're geolocating whether or not the worker was at the consumer's house. That freed up a lot of concerns around the consumer directed model. Is this person there or not? This also freed up
Sure.
a lot of concerns around home care agency. Is the worker there or not? And then using that app, our app is called Time for Care, and building in to our earlier points Maria and I have made about using that app to communicate useful information back to the user. So, what your compliance rating was in a pie chart, because we want you to be compliant, we want you to keep your Medicaid funding, being able to track the activities that were delivered during that shift, and then run aggregated reporting to see which of the assisted daily living activities is the most prevalent, getting the most support hours. It allowed us to do that and get better clarity into the needs levels. There's five different activities of daily living. Which one is it? Is it the food prep, the meal prep, the clothing? Like we can start to get granular on what that 4 hour shift looked like through technology and through just capturing a few basic data points. What were the top three activities you did over the 4 hour shift, and making that app very, very user friendly with graphics, graphic feedback, real time feedback. That's been a great breakthrough for both the integrity of the program and for the usability of it. So you can
For
say,
sure.
well, submitting a timesheet, is that still an option, old school style? Yeah, for ADA compliance, yes, we will always have multiple options. But a lot of people were thrilled about the technology piece because how do I get this timesheet to you? I need internet
For sure.
potentially, or a fax machine used to be the complaint. So that was a great example of technology greasing the wheels of the whole model to actually make it run better for a lot of people.
For sure. Yeah, and we think of that a lot. We see that a lot as well, and even kind of our chronic care management programs is that the overwhelming majority of people want to do the right thing. whether that's, staying compliant in, in the programs you're discussing, or like, or we would say staying compliant to their medication regime or their care plan. And it's about giving them the tools that make it easy for them to do that. And I think engaging, like, kind of, you're making it simple, streamlined, and ultimately motivating for them to take charge and ownership of that. And so often it's unfortunate because you see kind of like your processes or bad technology can lead to people kind of just dropping out and kind of just it's all too hard and kind of throwing it all out. And it's really kind of interesting to kind of hear how that's kind of applied in PPL's business as well. Because it's I think it is the big challenge in healthcare. Like, how do you make it simple and easy for people to make the right decisions and the right behaviors that ultimately benefits them, benefits the broader healthcare system as well over the long term, and makes that a simple process. Um, I think in terms of kind of my other kind of remaining questions would be, um, what excites you more broadly in the healthcare landscape over kind of the next 5 to 10 years, and what are kind of the big trends? I guess there's maybe a lot of doom scrolling on, like, the demographic trends, but like, what do you see, whether it's technology, whether it's policy change, whether it's very kind of very specific kind of changes to processes, that gets you both excited about where we could be in 5 years, 10 years time in healthcare?
Yeah, well, besides what we've been talking about, which, certainly the whole cultural competency and disability competency question, raising awareness on that is really big for me. And I'm glad to see more people talking about it. I would say that um, it's just easier now to um, arrange for healthcare from a administrative standpoint. Not so much you can always find the right provider for you, and we won't get into what the different health plans or programs cover, but I just find it so much easier when I can have my electronic health record and I can have my um, chronic condition management app like Perks, to keep me up to date on what I need to be doing to keep well and keep healthy, and do things like schedule appointments easily without like having to hang on a phone line for hours. So I'm excited about like those little things like that on how, again, it's not only in self-direction, but across the board, we're enabling more control over individuals' care. Mark?
Exciting.
And I'd add to that, I think there's still some populations that fully haven't gotten the benefit of a consumer-directed model. So Maria and I are hearing from states more often about the behavioral health population. Is there a service model that makes sense where they could pick maybe a peer support of their choosing, to help manage chronic behavioral health issues? I think the Veterans Administration has a self-directed, consumer-directed option that they would like to see grow and expand to serve more vets. So would we. And then maybe too far forward looking, but I think this country is going to get to a point where Medicaid Part B supplemental coverage is going to have to include some home care hours that should rightfully be able to be self-directed as well, because the crisis is that real. And again, past 2030, everybody's going to be feeling it.
For sure. For sure. Fantastic. Well, I appreciate you both taking the time to discuss with us today, and really appreciate you everyone, and thanks everyone on the attendees for joining, and see you soon.
Thank you, Scott. Thanks for having us.
Thank you all.